Hello everyone. So today we are going to discuss motor neuron disease. So this disease we all know after the death of Professor Stephen Hawking uh, when he the year of 2018. We all know everything about him. He was a great physicist, cosmologist, mathematician, and he passed away because of progressive muscular paralysis due to motor neuron disease. But out of all the disease, the most commonest variety is amyotrophic lateral sclerosis, which we call as ALS. Amyotrophic lateral sclerosis, ALS. So when we go to this disease, we know just the name says a lot about this disease. So we'll discuss that thing. Okay, so there are plenty of motor neuron disease like Kennedy's disease, adult Tay-Sachs disease, then spinal muscular atrophy. But out of all those motor neuron disease, this is the most commonest one. This one is the most commonest one. That's why we'll discuss more into this disease. Alright. So let's start with amyotrophic lateral sclerosis. So first of all, we need to know what is the pathophysiology behind this. And apart from what is the motor neuron disease? Now we know this. So there are some upper motor neuron lesions, plus there are some lower motor neuron lesions, then goes to a variety of, it gives us a hint, okay, there is some motor neuron disease. But not everything is included. We'll discuss that thing in the clinical features. Okay, let's start with amyotrophic lateral sclerosis. Now, what is amyotrophic lateral sclerosis? Now, as the name suggests, I told you, amyotrophic lateral sclerosis means there is this factor. There is muscle atrophy. What is happening here? Happening here is muscle atrophy. Then we know the corticospinal tract. When the corticospinal tract it comes down to the spinal cord, okay, it 80% continues as the lateral corticospinal tract and 20% progress as the anterior corticospinal. So where they go into the spinal cord, they come into the lateral column. Okay, so they come into the lateral column. So this we are talking about the lateral corticospinal tract. Lateral corticospinal tract. So what happens here? There is something happens here. We'll discuss the pathophysiology. There is something happen here. Okay, in this column. So lateral sclerosis. Sclerosis means thickened. So when this part is thickened and not performing well, then we call this amyotrophic. So because of the thickening of this part, because it affects the lateral part of the corticospinal tract, and it is causing muscle atrophy. So together we call this amyotrophic lateral sclerosis. Okay, this is just a hint on what is this disease. Now we'll go to the pathophysiology. So let's understand what is the pathophysiology of motor neuron disease or amyotrophic lateral sclerosis. So pathophysiology. So in the pathophysiology there are two types of causes. There are two types of theories. Though there are environmental factors, genetic factors, toxins, so many things. But what is the exact pathogenesis is still not yet known. But we can come out with two theories. One is when there is excessive glutamate. This is one of the factors when there is excessive glutamate in the body. So this glutamate is a neurotransmitter. We all know that, and this is an excitatory type of neurotransmitter. So whenever there is any problem in the reuptake, means when there is decreased reuptake. So what happens? When there is decreased reuptake, this glutamate content goes high. The glutamate level in the body goes high. So they are the basic reasons for the death of motor neurons. This is one theory. So when there is a reduced uptake or reuptake of glutamate, then this glutamate goes high in the body, and this is found to be very, very responsible for death of the motor neurons. This is one theory. Next theory is the DNA repair theory. pathophysiology is the DNA repair mechanism. Okay, let me tell you about DNA repair mechanism. In our body, there is an important protein called TDP43. We have an important protein called TDP43. So what they do, they are the important component of our DNA repair thing. So what they are doing, they are important component of non-homologous repair. Non-homologous repair. Non-homologous repair. Now we all know from our biochemistry background that in our body we have two type of DNA repairs. Now every day in our normal day-to-day activities, our DNAs are damaged by environmental conditions, by radiations, by metabolic conditions. Our DNAs are damaged, and it is a part of our body that DNAs are repaired. Okay, so that is also one of the process called aging. With aging, our DNA goes on damaging more and more than the repair mechanism. So in our body, we have two mechanisms of DNA repair, right? So one is that, so when the DNA is break, when the double strand of the DNA breaks, one is that you can just ligate it. We stitch it. End-to-end stitching. End-to-end stitching. This DNA is broken, then it's end-to-end stitches. What is called as non-homologous repair. Okay? But the main disadvantage is that many informations are lost in this kind. The most common variety is the homologous repair. So in homologous repair, there is use of a template. Okay? So let me explain it like this. Suppose there is a break here. Suppose this DNA is breaked. So our body, they use a template. They will use so this is the broken copy, this is the template. So they use a template. So and then they will take exact measurement, and then they will reconstruct it here. So that is the homologous repair. So our body, thankfully, fortunately, our body is mostly repaired by homologous repair kind of mechanism. So what happens in non-homologous mechanism? In this mechanism, this end-to-end stitching, when the DNA goes bad or is broken down, this double strand, there is end-to-end stitching by TDP43. Now, we don't know the exact cause, but it is found when it is caused by, when the motor neuron disease is caused by genetic factors, that this enzyme or this protein goes severely down. So when our body is lacking of TDP43, this non-homologous repair cannot occur. As a result, the breakdown, this all broken DNA double strand, all this broken DNA double strand, they highly increase in the number. So you can imagine in a cell, when the broken DNAs are increased, so can this cell function? No, this cell machinery, the function part of the cell machinery gets stuck because of increasing level of broken DNA double strand. So this is the main pathology causing motor neuron disease, because this takes place in many of the places. Where does it take place? It takes place in the corticospinal, in the layer 5 of the cerebral cortex. We know in the cortex, cerebral cortex, okay, where from the pyramidal tract comes, in the layer 5, it can occur there. It can occur in the layer 5. Then going down, it can occur in the bulbar neurons. In the bulbar neurons in the medulla, which is responsible for the all our face, head, neck muscles, in the bulbar neurons. Then it can occur in the in the anterior horn cells, and it can occur in the spinal cord. So in all these 4 places, what happens? What can happen? The motor neurons, they start dying. Why they are dying? Because the cell machinery has stopped. Okay, the neurons start dying. Why? Because cell machinery has stopped. The repair mechanism is being stuck. The repair mechanism of our body, it cannot repair anymore. So damage is going on and on and on, which is also a vital process of aging, as I told you. And because of that increased load of this broken DNA double strands, this whole mechanism goes down, and these motor neurons, okay, these neurons, where they are in the site, in the layer 5 of cerebral cortex. We all know from here pyramidal tract starts. It can also take place in bulbar neurons, where in the medulla, bulbar means medulla, in the medulla where there is 9, 10, 11, 12 is there. And it can also happen in anterior horn cells and also can occur in spinal cord. So together, combined, when these things occurs, so there can be patchy infiltration, or it can be, you can say it's scattered. That's why the motor neuron is scattered. It may occur something here, some here, and together we get a combined picture of motor neuron disease. All right. So let's move to now. So the clinical manifestation, but we all know the etiology. There is a there is a big list of etiology here. But I can only tell you the few common ones. We cannot go to the whole list. But this is caused by environmental factors. It can cause by genetic factors. It can also cause by irradiations. And don't forget, it can cause by bacterial toxins also. And also it is caused by one important drug. So this is also asked in MCQs. Okay, phenytoin has a side effect of motor neuron disease. And another thing, strychnine. If you remember, strychnine was used as an important part of pesticides. And with progressive use of pesticides, when lots of pesticides were used injudiciously, then it did cause lots of cases of motor neuron disease. After that, which it was banned. So it comes as an MCQ. Strychnine can cause motor neuron disease. Phenytoin, an anticonvulsant drug, it can also cause motor neuron disease. Now let's go for clinical manifestations. So we all know now its pyramidal tract starts from, okay, this is the pyramidal tract, then coming to the medulla. Okay, this is the pyramidal tract coming into the medulla. Okay. And then spinal cord. Okay, so this is the medulla, this spinal cord, and this is the precentral area. So precentral area, we know this is the motor area. Okay, so here the corticospinal tract is coming. So some tracts might end here, and we call them as bulbar tract. Okay, so corticobulbar tract, the pink one. So this is the corticobulbar tract, and the black one is corticospinal tract. So 80% cross to the opposite side. So we know lateral column here. So this is lateral corticospinal tract, and then from here it terminates to the anterior horn cell. This is anterior side, this is posterior side, and it is terminating in the anterior horn cells. So from the pathophysiology, we know these motor neurons, they start dying. They may die here, they may die here, they may die here in the lateral column or anterior horn cell. So these all sites can be affected. So what are the sites? It can happen in cerebral cortex, layer 5. It can happen in the medulla, the bulbar portion, and then anterior horn cells, and then spinal cord. Yes. Alright. So now what happens here? First thing is that there is thinning of the corticospinal tract. Okay, you need to remember that there is thinning of corticospinal tract. So spinal thinning of corticospinal tract. The corticospinal tract, it loses the volume. So you can imagine some bunch of fibers coming down from the cortex to the medulla, but it has now, because of dying of the motor neurons at the layer 5, the whole volume has lost. So there is less corticospinal tract is now here. So what is happening in the lateral region? So this is the lateral region, lateral column, the 80% which cross. Now what's happening here? Okay, now what's happening here? Here because of the thinning of the corticospinal tract, these glial cells, they start in number, they increase in number. The glial cells, like oligodendrocytes, they are glial cells. So there are lots of glial cells multiplication here. Lots of volume of glial cells here. Because there is thinning and there is some empty space now. There is lots of free space because of the thinning of the corticospinal tract. So the glial cells, they increase in volume. So when the glial cells increase in the volume, there is what will happen? This part will become thick. So when it becomes thick, we call it in a term called sclerosis. So these anterior horn cells are involved. So it's supplying this nerve, peripheral nerve is coming and supplying the muscle bulk. So there is muscular atrophy as a result of this lower motor neuron type of paralysis occurs here. Okay. So as a result, there is muscular atrophy and there is sclerosis. Where in the sclerosis? Lateral side. So together we call it the amyotrophic lateral sclerosis. Sclerosis means thickening of the teeth. Okay. So together we call amyotrophic lateral sclerosis. So you can imagine from your side that there will be some lower motor neuron problems. There will be some lower motor neuron problems here. There will be some upper motor neuron problems here. So together we call this motor neuron disease. So it's not necessary that the person will start with upper motor neuron disease. It differs from person to person. So a patient A may have initially lower motor neuron symptoms and after a few years he develop upper motor neuron symptoms. But eventually, in any case, they will have both upper motor neuron lesions and lower motor neuron lesions. So let's try to understand now what are the basic clinical manifestations. So in the lower motor neuron things, we'll see there is asymmetric muscle weakness, asymmetric muscular weakness. It starts with asymmetric muscle weakness and it will gradually go to symmetric type. This is a different variety. Asymmetric may eventually lead to symmetric type. So there is a complaining of asymmetric muscle weakness, and if detailed history is taken, it is often found that person may have in early morning hours he may have he may have experienced some cramping with some volitional movements. So cramping plus volitional movements. Now we all know what are volitional movements when we are when you use the willpower to execute your movement. That is called volitional movement. That is being now very much it is encouraged for the paralytic people to move their legs with using their willpower. So it has been seen during in early morning hours in the bed, while stretching their body, they may have developed some asymmetric muscle weakness and they developed it. So which only comes in detailed history. There is cramping and volitional movement. That is number one clinical features. Number two, in the clinical manifestation, he will have muscular atrophy that comes from the name amyotrophic. But remember, this is progressive muscular atrophy. Okay, so there will be progressive muscular atrophy. That is the number two. And so why this atrophy is there? Because all these neurons, they shrink. They are shrinking of the neurons. There is thinning of the spinal tract, which controls the voluntary muscles. So, and there is a lower motor neuron paralysis. So as a result, there is all leading to, it is a progressive. So as more and more neurons die, as it's more and more thin up, so the atrophy will progress more and more. So here we know this is lower motor neuron type of paralysis. Plus number three, don't forget fasciculation, which is a motor twitch. Fasciculations is very, very common here in motor neuron disease or asymmetric muscular atrophy. Okay, let's go to number four then. So you have to take this in mind that in the hand, extensor group of muscles are more commonly affected than proximal group of muscles. Okay, so all the extensor movement of the hand, they are affected. So extensor group of muscles in the hands. Then there will be some bulbar symptoms. Bulbar symptoms. So we know that in the pyramid, in the medulla, there are these are 4 cranial nerves nuclei are in the medulla, which are 9th, 10, 11, 12. Okay. Also from the last class, we know they supply LPST. L for, so what is L for larynx, P for pharynx, S for soft palate, and T for tongue. So there will be bulbar symptoms sooner or later when the disease will move on, it's going on and on. So all the bulbar symptoms like problem in chewing, difficulty in swallowing, some sort of then what is called the voice, regurgitations, drooling of saliva, it may occur. Along with bulbar, when it progresses more, there can be pseudobulbar paralysis. Pseudobulbar symptoms can also be there. So we know what is pseudobulbar when along with 9, 10, 11, 12, there is involvement of 5th nerve or 7th nerve, facial nerve. So facial nerve paralysis, some signs and symptoms of facial nerve paralysis, facial muscles, especially pathological laughing when a person cannot stop his laugh, when a person cannot stop his crying because of loss of control, because of the loss of control of the facial muscles. So pathological laughing is also a variety included here, pathological laughing. That is because of involvement of 7th nerve, facial muscles. So that is also involved here. So that is clinical features. And what else? Now we have involved bulbar, we have involved pseudobulbar, now lower motor neurons, then don't forget to include upper motor neurons. Okay. So I remove this one and upper motor neurons. So we come to number 7. So upper motor neuron symptoms. So what are the upper motor neuron symptoms? They are the increased jerks or increased tendon jerks, increased tendon reflex. These are the upper motor neurons very commonly associated, and plus there is spasticity which comes along with upper motor neuron type of paralysis. So these are the basic clinical features. So what are the things you remember in the clinical features? Look, we have gone with lower motor neuron type of paralysis, progressive atrophy, number 3 is fasciculations. There will be some hand muscle atrophy, but it's more common in extensor group of muscles. There will be some bulbar signs, there will be some pseudobulbar signs, there will be upper motor neuron signs. But what you will need to remember, because it is very commonly coming in the MCQs, the what are not affected, because this thing is important when you do a differential diagnosis. So what are not affected? So remember the term called BBC. So what are the things that are not affected in motor neuron disease? This is very important for any medical graduates. This is for sensory system. Sensory system is totally not affected here. Person can feel his touch, pain, proprioception, everything is totally intact. So sensory system is not affected in motor neuron disease. Do remember that. Number 2, extraocular muscles. All our extraocular muscles like 3rd, 4th, 6th, all these cranial nerves. So extraocular muscles, ocular muscles are not involved. Extraocular muscles are not involved. Okay, we are discussing what are not involved. Extraocular muscles are not involved, sensory system is not involved. Then this for bowel. There is no bowel symptoms in motor neuron disease. And B for bladder. Urinary bladder is not affected And very interestingly, the intelligence part, the cognitive part is not affected. So there is so you can like, if you go to the situation where Professor Stephen Hawking, who is the main research scientist and physicist in NASA, he was still doing all the conference, all the his seminars, and he still was teaching because the cognitive part was not affected. Cognitive part was not affected. So there is no affection or affection of the cognitive part. So that are the things that are very important in motor neuron disease. We all know the clinical features. There are some upper motor neuron, some lower motor neuron, but you have to keep it in mind when you do the differential diagnosis. That is called SOBBC. So sensory system, ocular muscles, bowel, bladder, and cognition not affected. So there is no cure in the treatment part. We know there is no cure here. Only we can do some palliative treatment. We can increase the quality of life. But there is a new drug that is being very much now in market, and it is being used widespread. But it's called Riluzole. This is also a very popular drug, widely used, Riluzole, but it has some side effects. But anyways, it is being used and it is asked in MCQ. That's why I'm mentioning this drug, Riluzole, okay, which has got side effects of like weight loss, dizziness, and many things. Okay, we are not going into the treatment proper. There is no cure. Remember, there is no cure. So because the cells are dying, motor neurons are dying, and there's thinning of the corticospinal tract, loss of the volume of corticospinal tract. As a result, in that empty space, there is gliosis, all because the glial cells, they multiply, and the lateral spinal and the lateral column of the spinal cord, they become thick, and as a result, we call this amyotrophic lateral sclerosis. Lateral part of the spinal cord is thickened, so lateral sclerosis, leading to progressive muscular atrophy. So amyotrophic lateral sclerosis, which is the most commonest variety of motor neuron disease. So that's all about motor neuron disease. Thank you very much.